Hello everyone, welcome back to the Neet Pg Pyqs series. Here in this question, a 58-year-old man present with progressive gait unsteadiness. On examination, his Romberg test is positive. He also has an absent pupillary light reflex, but accommodation reflex is intact. Past history is significant for untreated painless genital ulcer 20 years ago. Which of the following investigation would be the most appropriate to confirm the diagnosis? Option A, VDRL test of cerebrospinal fluid. Option B, FTA ABS fluorescent treponemal antibody absorption test, and TPHA treponema palladium hemagglutination assay. Option D, RPR rapid plasma reagin test. So here in this question, now let's break this down option by option, because in the exam it's not just about the knowing the right answer, it's about knowing why the others are wrong too. So here in this option A, VDRL test, option A, VDRL test, CSF VDRL is considered the diagnostic test for neurosyphilis. Okay, neurosyphilis. Why? Because it has very high specificity, and the sensitivity may not be 100%, but when positive in CSF, it is considered confirmatory. So this is why in a patient with TAPS dorsalis like positive Romberg ataxia, CSF VDR is the gold standard investigation. So here the correct answer is the option A, but let's discuss option B, option C, and option D also. Option B, FTA ABS. So FTA ABS is a treponemal test. It's a highly sensitive and can detect antibody very early in syphilis. But the problem is it stays positive for life once a person is infected. So if you test FTA ABS in a patient who had syphilis 20 years ago, so it will still be positive. That means it cannot differentiate between fast infection and active neurosyphilis. So good screening test, but not diagnostic for neurosyphilis. Option C, TPHA. So TPHA is another treponemal specific test similar to FDA ABS, very sensitive and detect lifelong infection history. Again, the limitation is once positive, always positive. So it's excellent for screening and for confirming exposure, but not useful to confirm neurosyphilis actively. So here we have to remember that if both TPHA and VDRL are positive, most likely active syphilis. If only TPHA positive, that means it's all treated infection. Okay, so here option C also is not correct. Now option D, RPR. So RPR is a non-treponemal test similar to VDRL, but it is usually done on blood, not CSF, and it detect antibody against cardiolipin lecithin cholesterol antigen. Okay, and used for screening and monitoring treatment response, because titers fall with therapy. But in the context of neurosyphilis, it is not reliable in CSF, and that's why it's not considered diagnostic. And so option C is, or option D is also not correct. So now let's discuss the most important points about this topic. Gold standard for syphilis is CSF VDRL. Then diagnostic for neurosyphilis is CSF VDRL, high specificity. Then the second point is sensitive, stay positive for life, but not diagnostic. Okay, but not diagnostic is FTA ABS or TPHA. Then the third point is that used for screening, not CSF diagnosis, is RPR, that is used for screening, not not CSF diagnosis. And the fourth and most important point about this is hallmark of neurosyphilis is Arzel Robertson pupil. Accommodate but does not react, that is hallmark of neurosyphilis. And the drug of choice is aqueous crystalline penicillin G. Penicillin G IV, that is the drug of choice. So these are the most important 5 points about this topic. And thank you for watching this video. Please subscribe this Medicogram channel.